Good morning, everyone, and welcome to day two of our 2023 iteration of the UWI SCMR Research Day under the theme Reflect, Refocus, Renew. We began last evening with prayer from Dr. Francis Williams, the Medical Chief of Staff of the Princess Margaret Hospital, followed by remarks from Dr. Sharita Moxie of the Ministry of Health and Wellness, and Dr. Corinne Sinqui, the director of UWI SCMR, the Bahamas. The session then focused on the topic of healthcare outcomes. The first speaker, Dr. Robin Roberts, discussed prostate cancer screening, screen or not to screen, and the benefits of insurance for all. The second speaker, Professor Emerita Celia Christie, discussed the evolving dengue epidemic in the Caribbean. And the session was brilliantly moderated by Dr. Sabika Pinda Butler. So I'll be your moderator for this session, and we're delighted to have you all here today for a second session, which focuses on research ethics and legal considerations in healthcare. This is a workshop, and as such, no residents will present in this section. However, we'll be hearing from four distinguished keynote speakers who will share their experience on a range of important topics. So our speakers will include Dr. Albinette Rule, who will discuss approaches to reducing litigation in hospital medicine, Dr. Kenneth James, who will look at research and publication ethics, adhering to principles, avoiding pitfalls, and additionally, Dr. David Barnett will venture in legal pitfalls in stem cell research. And finally, Dr. Brian Charles will have a session with you on staying out of trouble, which is an introduction to safe practice. Each speaker will be given 20 to 25 minutes to talk, and then there will be a 5 minutes questions and answers. And speakers, I ask that you will, when you reach like 2 minutes to go, I'll let you know, and you'll be given permission to share your screen and to control your own slide. For attendees, I'm asking you to close your microphone upon entry, keep the questions until the end, and at that time, you can raise your hands for questions or comments, or to post your questions or comments in the chat. Personally, I prefer to have persons speak, as it kind of keep that human-to-human connection going. Our first speaker is Dr. Kenneth James, Senior Lecturer and Head of the Department of Community Health and Psychiatry at UWI Mona in Jamaica. He's trained initially as a medical doctor and followed further public health training. His journey encompassed stops in the Jamaican healthcare system, Boston University School of Public Health, where he was an assistant professor in the Department of International Health and the UWI Mona campus. And he has worked on health projects and consultancies in various countries, including the Democratic Republic of the Congo, Nepal, Tunisia, the Republic of Guinea, Barbados, and Jamaica. He has authored and co-authored over 70 peer-reviewed journal articles and 10 technical reports, wrote in public health issues related to gerontology, separated and abandoned children, COVID-19, and the psychometric performance of research instruments. As a lecturer, he engages undergraduate and graduate students in the fields of epidemiology, biostatistics, evidence-based medicine, and primary healthcare. His professional awards include the prestigious Norman Scotch Teaching Award for Excellence in Public Health Teaching at the Boston University, and the Principal's Award for Best Research Publication in the Faculty of Medical Sciences at the UWI in 2018. He described himself as an easygoing, humble person who enjoys a good drink for relaxation. And he believes that knowledge is one of things in life which, when shared, results in no one being poor. So attendees, I invite you to welcome him and just pay some attention as we have a good session. Dr. James, over to you.
Let me unmute myself and then share my screen. And then say, okay. Good morning to all. And I'm very happy to be here making this presentation. Sometimes I don't know what I'm getting myself into, but I hope that some of the things that I happen to share here will be useful for you. There's no question that in the world of today, publication, research and publication ethics have assumed greater and greater importance. With a wide range, a panoply of options for publication, and with the push for research, the impetus to produce research creates many dangers. And so today we want to talk about research and publication issues and looking at what can we do to avoid pitfalls? What are some of those pitfalls? And how can we try to adhere and navigate this thorny landscape? The presentation will by and large take the following outline. I will talk briefly about what really publication ethics is, the major issues and concerns, and we'll go into a number of these, and then to point to options for best practices, standards, and guidelines, and point to where they exist. I will briefly also talk about artificial intelligence, and it's just a minor touch on this matter because I am no expert in that field, but it impinges somewhat on the business of publication ethics. When we talk about publication ethics, what do we really mean? We are really into rules, guidelines that govern the conduct of the process of research and the subsequent publication. And for this, I'm going to focus largely on the publication end. And so when we produce our scientific and scholarly work, there is a process, there is a modus operandi which we ought to follow if we are going to be ethically, i.e. morally sound and just and do the work and the participants in our study and the academic community justice. It is through adherence to these ethical standards that we ensure high quality publications, that we engender public trust in our findings, and that people receive credit for the work they have done. It's important to pay attention to publication ethics because when you think about it, the archiving of journals is one of the cornerstones upon which academic endeavors exist. We use those archives to retrieve material, and we use the repositories for storage of newly published material. It is through these archives, it is through the published material that we communicate with each other in our field. Consequently, we want a repository that we have faith in, that we trust. We want a repository that gives due recognition for the work of researchers and institutions, a repository that guarantees article autonomy. And what do I mean by article autonomy? In the same way that you have carved out yourself an identity, something that's unique for you. So you have a name, you have a personality, you have a birth certificate, you have a passport, you have an address. Similarly, we have to do that if we are not going to compromise certain things, as we shall see later. We have to do that for articles, so that each article becomes a uniquely distinct product when published. And we now have the situation where we now have a unique IDs, we have titles, we have unique websites from which web addresses where these can be found. And so, like your library, this is a tagging of the articles. If we do not do that, we run the risk of article duplication. We run the risk of not finding what we need when we need it in the published sphere. Publication ethics also speaks to the issue that we must respect the privacy of the stakeholders in the research and publication process. If we do not ethically operate and protect our subjects and our researchers, we could run into trouble. If you think about this, imagine a research where we've conducted some kind of new surgical intervention, a research project, where we've examined some new surgical intervention. And then at the end, we find out 90% of persons have survived, 10% of persons have died. Imagine the situation if we were to reveal the names of those who died, or worse, reveal the name of the surgeon who operated when those persons died. Furthermore, when we do research and interview key informants, we need to protect their privacy to the extent that the information they give are useful to us without compromising them in their own social, professional, and work spheres. Without that, we will not get the information we need. Publication ethics is also important because it speaks to issues around copyright, licensing stipulates, and the use of material in the published sphere. There are some major issues and concerns, however, and we are going to take a look at these. They relate to approval and consent, criteria not being met, data fabrication and falsification, plagiarism, submission fraud, and there are this could take various forms, we'll discuss them, improper author contribution and attribution, and undeclared conflict of interest. So let's look at approval and consent. Authors and researchers must be aware of guidelines and adhere to the rules set up often by the publishing companies as well as their own ethical reviews or institutional review boards. One of those requirements is often that you obtain consent from all study participants. This is really important. It should not be taken lightly, nor should it be an afterthought. It has to be brought up front early in the design and conceptual process, and certainly must be written up in the study protocol. To produce our published material where the participants have not given informed consent is a clear breach of rights and a clear breach of ethical and moral principles. Imagine that you have if you have done this, you probably have done that and exploited vulnerable populations. You probably will in turn hire study participants compromising their own participation in future studies. And at the same time, the autonomy that the study participants have over their voluntary participation may be at risk. These we know are critical in carrying out research. Data fabrication and falsification is another issue that arises in the realm of publication ethics. We often find fabrication occurring where researchers draw conclusions about data that is not actually generated by the study. Or we have some study data which has been massaged and let's call it twisted in such a way to produce desired results. In this case, alteration of the data and not representing what was truly collected, falsification. They are really about, if you take it at heart, attempts to conceal the truth. And falsification and fabrication can occur not only in the writing part of the report, but also in the visual images that are presented in the report. These are extremely serious forms of misconduct, and the consequences can be severe, from alienation and expulsion from the publishing community, from internal academic discipline from your own institutions, and you may even suffer reputational damage to the extent that you are placed on a bad blacklist and nobody wants to give you any more grants. Nobody will publish anything that is submitted by you or your co-authors. In some jurisdictions, you could even be fined for a criminal offense for fabricating and falsifying data. Plagiarism is another thorny aspect. Many of us are familiar with the term, and it speaks to really the use of published or unpublished work by another author in your own manuscript without either consent, without the credit and due acknowledgement of the source. In other words, trying to pull the wool over our eyes, passing it off as your own. At the heart of plagiarism is really literary theft. It is about lying and stealing. It is about kidnapping somebody else's ideas, words, or work and taking it and presenting it to some extent as your own. At the heart of plagiarism is deceit, and that's why it is taken so seriously. We encounter common types of plagiarism. Complete plagiarism, where you wholesalely steal another author's work and present it in your name. Source-based, where the references are incorrect, or you make up non-existent sources. Commonly, they copy text from other document word for word. And then there's paraphrasing plagiarism, where you make minor changes to somebody's writing, rather than writing the dog barks and bites, you write the canine barks and bites. Cosmetic changes. Mosaic plagiarism is something we encounter, and in today's work, the cut and paste document exemplifies this. In fact, some people say that when you commit the offense of mosaic plagiarism, you're really an artist and not a scientist. Accidental plagiarism, that's your fault. It's because you haven't taken care, and without due care, you have neglected to edit your document, look for possible plagiarism, and then you submit it only to find that you had overlooked it. Inaccurate authorship has also been added to the realm of plagiarism. People argue as to whether it is plagiarism or not. In any case, whether you classify it as plagiarism or not, it is a breach of trust. It's also an attempt by others to be authors when they are not, but it can also work the other way, where somebody who ought to be an author is unjustly excluded. The last point I mentioned here on plagiarism relates to self or auto-plagiarism. And the question has often been asked, can you steal from yourself? The answer is yes. Remember, at the heart of publication ethics is the attempt to be genuine. So if you copy and paste elements from previously published work, or you get previously published work and submit it, it is in essence some level of dishonesty and theft. It's like the student who, having done original work, submitted the homework for a class, got a grade for it, then takes the same work without doing much more and submits it to another class for another grade. So in other words, you want to be rewarded twice for work that you have only done once. The other issue around self-plagiarism surrounds copyright. Often when you submit to a journal, you do not necessarily have copyright over the material. So you're not necessarily free to use it willy-nilly as you please. And so self-plagiarism is possible, and you have to be careful about that. Many institutions will have policies regarding plagiarism, and I've just put here a couple of websites where for UWI, these are some of the websites that you may find being useful, and it sets out what plagiarism is with regard to that institution, the penalties and procedures for dealing with it. In the international sphere, the Committee on Publication Ethics provides guidelines about the processes to be followed when plagiarism is detected, whether it's detected in the review phase, when the document has been submitted, or even when it's detected after publication. And one of the worst scenarios that can happen to any researcher is to have their article flagged for plagiarism after publication. It often involves the journal issuing a withdrawal and publishing the article to be withdrawn, as well as the authors who were involved. And then they have to circulate that on various websites, on various editors' lists. It really doesn't look good. And pretty much it stays there forever. It's not something that you can erase on your own. So there's help. Use various software to help check plagiarism. That is your responsibility. When using the software, the impetus, the drive is for you to check yourself, not for somebody to discover that you have. Various programs exist. I've just put up 2 or 3 of them here, but there's Bard and Grammarly, and so on. Many journals will require you to put your material through a plagiarism checker before they accept it for review and possible publication. 4th problem, submission fraud. 2 types of the submission fraud largely exist: simultaneous submission as well as duplicate submission. In simultaneous submission, you essentially have a paper and you submit it to many journals at one time. You may be arguing that, okay, let me submit it to journal A as well as journal B, because journal A might not accept it, and I've got a head start with regard to journal B. However, this presents problems because if both were to accept the article, then we have problems with article autonomy and identification. And also, many journals will say that what they wish to produce is original research. Once one journal has published it already, for the second journal, it cannot count as original research. Many journals now require that you give a statement saying that you have not submitted the manuscript elsewhere while they are considering it for review and publication. In the case of papers for scientific conferences, you can present, and that does not prohibit you from submitting later to a peer-reviewed journal. So it's one of the acceptance. So if I presented a paper here at this conference, I might go on and also publish that paper in a peer-reviewed journal. Duplicate publication. This occurs when you submit a new manuscript. But guess what? It's the same hypothesis, it's the same data, it's the same discussion points, and you make the same conclusions. All you might tweak is the paragraphs, the introductory paragraphs. You might tweak a little bit of the methods, a bit, but essentially, in terms of the phrasing, but essentially, it's the same paper. It's somewhat like plagiarism, but instead of copying the phrases word for word, we just use new language, but it's the same data, same images, same hypothesis, same results, and we call it another paper. That essentially is, again, fraud, deceit, presenting an already published, submitted manuscript elsewhere, and perhaps published elsewhere, as if it were new. Duplicate publication constitutes an offense which could be minor or major. Major offenses are where the authors seek to conceal redundancy by doing cosmetic changes, changing the title. So instead of calling it Publication Ethics in the Bahamas, Problems of Today, I change it to something like Publication Challenges, Bahamian Dilemma. But it's the same thing. And now you change the title and you get even more creative. Change the order of the authors. And you don't refer to the previous paper that was published. That's major. Minor offenses can occur when you do what's called salami slicing. So you take the publication. Let's say that you had a publication looking at hypertension on New Providence, Grand Bahama, and Abaco, and you produce it and you say the prevalence in the study was X%, and males were found to have greater risk of whatever than females. And you make conclusions about the research. Someone might say, aha, you know what I'm going to do? I'm going to just do the same thing, but instead of all the data for the 3 countries, I'm just going to take out the Abaco or the New Providence data. Well, that's what we call salami slicing. So everything else is similar, except we've just got a slightly different data set. But the whole business of the writing, the methods, and the form of the analysis is exactly the same. In fact, it could be argued that the subgroup analysis should have been part of the first major paper. Authorship, thorny problem, but journals, there are outlines about what can be done and who should be qualified as an author. So to be an author, the International Committee of Medical Journal Editors states that to be an author, you should contribute substantially to the conduct of that study, either in its conception and design, in the data collection and acquisition, in the analysis or in the interpretation, or drafting and revising the article for intellectual content, not just for grammar, intellectual content. So just correcting the S's and the these and so on does not qualify for authorship. You could also be a critical reviewer and an approver of the final version. And this will require that you intellectually engage the document, and therefore you would qualify as a possible author. Conflict of interest is something we encounter in publication, the publication process. This is really about when an individual's personal interest, whether it be interest, family, friends, donors, sponsors, financial or other social factors, could compromise, could influence your judgment, and therefore the conclusions and the actions which subsequently follow may not simply be what would occur were these factors not at work. So what you do if there are possible conflicts, if there's possible conflicts of interest, declare them. Once you do so, then it is up to the reader to determine to what extent they think the conflict of interest could have impacted the study. So leave it, be open about it, let others decide. An emerging problem is inappropriate self-citation. Right now, many of us have realized that it's not the publishing of the paper that is so important, but sometimes the number of citations that that paper has received. This is now more and more being used in determining academic promotion. So there are factors and metrics out there that incorporate the number of citations, for example, the G index and the H index, And that now has caused people to yield sometimes to the temptation of self-citation. So you're writing a paper, and you, in your literature review, there is something that is not really relevant to the issue being addressed, but it's something that you worked on and you published before. So you sneak it in, even if it's only a phrase that is marginally applicable to what you are doing now. You sneak it in, so it's one more citation when your research is eventually published. This, in a sense, is what we call intellectual hiding, intellectual concealment of your research, or unjust intellectual enhancement of your research prowess. I had been at the point where I just mentioned that there are best practices and standards with respect to publication ethics. And WAMI has outlined these principles, and they're there for all to see. Anybody can go there and, you know, check the website. And also the Committee on Publication Ethics is another good resource for that. All of these best practices and standards speak to a number of issues. They really target talking about the journal itself. They have recommendations about websites. And so the standards and practices not only speak to the person who is submitting, but also to the journal that is going to be considering it for publication. And there are a number of things that there, and this will also help us to decide whether this journal is likely to be following ethical standards with regard to the practice of publication of scientific research. We won't go into all of these, but, you know, they're there to guide us in case you are considering publishing, who you should publish with, what you should look for. Another good resource regarding this is the COPE, the Committee on Public Ethics, and they seek to entrench a culture of publishing such that these ethical practices become the norm. If you click on that website, it will take you to there in detail. Many journals also have on their websites a little section that speaks to the conduct, with regard to their conduct, their responsibilities, as well as the author's responsibilities with respect to publication. I have not spent much time on the research element itself. Many of you are familiar with these, that basic research requires that you address issues of privacy, informed consent, institutional review approval, safety, data security, data monitoring, publication of results, and in some cases, other specialties, such as the consideration of equipoise in clinical trials. But these are there and should be part of your research protocol. In fact, people argue that publication ethics has embodied within the fact that that research should have met certain ethical standards in the first case. The last slide I want to talk about is just on artificial intelligence. It is with us. It has created a number of challenges with regard to how we handled it. How do you know who is an author? How do you know if the data is real? What is it that is being produced? There are lots of sources for the software that produce the papers, if you want to, for lack of a better word, ChatGPT, Bard, Human AI, Perplexity. You can all get this generated. And the big thing is this ethical? Who is the author? And can you trust the papers and the research that is so generated? You know that this is going to be challenging. There are articles here about AI versus original abstracts. That's a good one. You can go to ChatGPT and you can try some of these. And just for the interest. Let me just escape from this. To Perplex AI. And what I did for the joke of it just this morning was to ask it to give a paper, and I'll just do this for a minute and then I'll be done. Give paper on publication ethics. And it will actually generate that paper for you. And here it is, paper generated. Publication ethics is that, and so on, and so on, and so on, and so on. And the question is this original work? Who is the author? If I took this and put it in a manuscript, am I cheating? Am I doing the morally correct thing? And it's a lot of problems. When such papers are generated, sometimes what happens now is that we can actually try to check if this was an AI thing. And here's one of the sources, Scrib AI detector. If you run it, for example, ChatGPT and Bard, since it's a workshop, I'm just going to do one example. And I said, okay, if I use ChatGPT to check it, analyze the text, and it will produce the runs. And that essay, which is what I put in, tells me it was likely generated, 100% likely generated by AI. And if you do it with any one of the other stuff, you might get slightly different reporting for various things. So the essence of it is that you can try to do this if you are in publishing as a school. I mean, you often have a journal that may be something that you're going to get into, and you may have to start to do that. Others, for us, the idea is that we should probably not rely on AI, but seek to generate the papers. AI is useful in certain aspects, but be careful not to overuse it. And then these are my references. And for people in the Bahamas, when you come to Jamaica, I know you have lots of beaches. You can actually come and try one of our river trips. So thank you, and I'm open to questions. Conference chair, just wanted to address a question was asked in the chat earlier. Does AI software give sources of information so that plagiarism can be avoided? And the answer is yes, some of it does. And I don't know if I can share my screen for 20 seconds. Just to show there that this is in my AI essay. You will see here these numbers which actually give you the sources from where these were taken. And if you click on the sources, you will see the paper from which that idea was derived. However, that itself does not, as the person asks, can you get the sources to help avoid plagiarism? Yes, looking at the sources, but you really need to read through those sources. And you may find that sometimes when you read, the impression that the conclusions AI has made is not necessarily what you would draw from the article, having read it itself. So I was just saying that in this, the AI, you will see the numbers of the sources listed. And if you click on that, it will take you to the original source from which the AI drew its conclusion. But read, don't rely on it. Sometimes the AI may interpret something totally different from what the authors themselves have given. Sometimes it's on target, but the responsibility remains on you to go through whatever is produced and try to perhaps read that and put it in your own words, see what you glean from it, and write your own paper. So it can be used as an adjunct to point you where you might want to look. Thank you.
Our next speaker is Dr. Abinet Rule. And Dr. Abinet Rule is an innovative healthcare catalyst with over 30 years of experience in this field. She commenced her career as a registered nurse and midwife in public and private healthcare sectors. And at present, she serves as the managing director for the Public Hospitals Authority here in the Bahamas. And 2 decades in her niche have furnished her with a wealth of experience driving continuous patient and safety improvements across hospitals. And she proves to be an ardent believer in cultivating a culture of patient healing through hospitals and carrying on collaborative operations. She is consistently developing, building, and expanding quality healthcare programs while streamlining and strengthening processes and identifying inefficiencies. Dr. Rule successfully completed her bachelor's in law with second-class honors from the University of London in the UK and continued on to achieve her master's in business administration with specialization in risk management and thereafter a PhD in organizational leadership from Michael University. She was successful in her placement at the Eugene de Pouche Law School, where she served as president and graduated in September 2008. Upon graduating, she also received an award for the best all-round student, and she was called to the Bahamian Bar in 2008. Dr. Rule continued her education and obtained advanced training in healthcare risk and quality management, and is a certified professional in healthcare risk management from the American Hospital Association, occupational health and safety specialist, certified international project manager, certified risk manager, and a wound care specialist. She's also trained as an international accredited mediator from the London School of Mediation and has a master's certificate in healthcare leadership from Cornell University. Dr. Rule is a natural leader with a talent for motivating teams by drawing on exceptional communication and presentation skills. She recently launched her business as the Next Level Consultant. She's extremely resourceful and can effectively foster collaborations at all levels, from frontline staff to board level leadership, and to achieve favorable outcomes. As a certified John Maxwell speaker, trainer, coach, and DIC personality assessment consultant, she possesses a wealth of experience to guide individuals and organizations toward personal and professional growth. She's also the author of the book, The RICH Experience, Expectations of Parents and Providers. And she's married with 2 adult children, a daughter-in-law, and is Nana to a precious grandson, Armani King Rule. So we have Dr. Rule.
Good morning. Thank you so much for joining me on this topic, how to approach reducing litigation in hospital medicine. I am Dr. Abinette Rule, and I'm Managing Director of the Public Hospitals Authority, and I am also a counsel and attorney at law. Our focus today is really to talk about how do we deal with some of the issues that plague healthcare globally. And so today, we really have a singular objective, and that really is to understand the challenges hospital medicine faces regarding litigation and have the ability to learn from effective strategies and best practices to minimize legal risks. And so I want you to be able to just sit back, think about some of the things that we encounter in our hospital settings, and really think about how we may move forward with the strategies to, in some instances, really eliminate, but in most instances, minimize the exposure. One of the most important things, though, I like to start with when I'm talking about litigation is really to talk about the effect that litigation has on individuals as well as the effect, and they're totally opposite, right? And so when we talk about litigation and potential litigation, everybody gets excited, they get concerned, they become defensive. But I want us to understand from the very beginning that when we talk about litigation, it really affects 4 entities in healthcare. It really affects the patients and by extension, their families. And it also affects the providers because in some instances, we find that persons did not come to work on any given day to cause harm to patients. And so the providers really are affected by the litigation. Also, it affects the public, the public's perception of the level of care that we are providing to our patients. And sometimes it causes them to lose respect and trust in us. And then also, the fourth P is an enterprise that really speaks to the organization. It really affects the organization financially as well as our brand. So I really want you to understand that when we talk about litigation, there are four victims. And so we always have to be concerned about the providers as well as to ensure that they are getting the emotional support that they need, as well as other administrative supports when we move forward. And so I describe them as the four P's that really affect and affect us as a result of potential and actual litigation. Well, when we talk about litigation in hospitals, I just put a listing very briefly of some of the 9 frequent occurrences that we see in terms of writ of summons that really come to us, and it speaks about the level of cases that we see. So, a lot of times we have claims that are called medical malpractices, and these involve those things resulting in errors or harms to patient. And we see a lot of that in surgical misadventures, and you give an example of that. A patient comes in for a specific procedure, an invasive procedure, and as a result of achieving a successful result of that, inadvertently, and sometimes because of adjacent organs, etc., other organs become affected, and they're causing harm to the patient. And in some instances, the patients do move forward with litigation. And then there's the negligent claims, they're the ones where the provider as well as the facility was to ensure that a certain standard was kept. And in these instances, the patients seem to think that there was a breach of duty. And a lot of times we're now seeing it in cases where there's lack of supervision. And we'll get to talk about that later on in this presentation. And also the lack of monitoring. Very important. And you're going to see, I want to speak about a case in a few minutes without disclosing who the patient is. A case that really caused us issues where if we had followed the protocol, we would have been able to minimize our level of exposure. And then the lack of informed consent. And we're going to talk about that as well. Misdiagnosis, and this is something persons are holding us accountable. And yes, as in every specialty, you get misdiagnosis. Sometimes you go and take your car to a mechanic and they tell you that you need this certain part and you've invested heavily in achieving that. And at the end of the day, it was something different. And, in those instances, people don't go back and say, I'm going to sue, the mechanic because he wasted my time. But, they have a choice of not going back. But in healthcare, persons will come back and sue us for misdiagnosis. The fifth one is delay in diagnostic results and management. And that one is easy to understand because the longer we take to advise persons on what their diagnostic results are, then that in itself delays their ability for either further consultation and or management that can have a real terrible effect on the outcome of their particular illness and or disease. Also, harm secondary to defective medical devices or pharmaceuticals. And I know years ago in the US, they came out with a Safe Medical Device Act that ensured that when devices are used in hospitals, there are certain parameters to ensure that they meet the quality standard, to ensure that they are regularly, preventatively maintained, to ensure that if they are inoperable, that they are removed, and also to ensure that any devices that come from the external to be used, they follow the process of having it vetted, reviewed, and assessed by biomedical professionals. And the same thing with pharmaceuticals, the quality of the drugs, just to make sure that we're using safe medicine. And so it's very, very important. Also, breach of privacy, confidentiality. A lot of times we see that as it relates to patients' medical records, also giving information about the patient without the patient's approval. And there are only limited times that you can do that, which includes orders from the court, as well as if somebody else who had carriage of that particular patient, whether by having a PA to ensure that persons can handle their affairs if they are unable to. That's the only time. Outside of that, we have to ensure that we follow the privacy rules. And so the Bahamas now has the Data Protection Act, which really clearly speaks about the use of information and the disbursement of information to a third party. And so we have to be very careful about that. In some instances, we get wrongful death suits, as well as one of the newer things that I'm seeing now is allegations of discrimination. And in the Bahamas, this is something that's relatively new. Persons are saying that the level of care that they have received was substandard. They felt that based on their gender, their race, ethnicity, or even disability, they were not given a fair chance to receive the level of care and treatment as somebody else who was of a different race, gender, ethnicity. And so we have to be very, very careful. And so these are some of the things that we're seeing not only in the Bahamas and in the public sector, but also globally. But there are a bit more. And I want to just dive deeply into some of the areas where I see we're not doing things right and really speak about what I call the correct way or strategies to mitigate and eliminate. And so we're going to concentrate now on what I call some of the challenges that I see. We have seen some progress, but some that we really, really need to improve upon. And one of the first things, like I said, is the informed consent. And we all know, being in healthcare, that that's a process that really is not a unilateral decision. It's one of discussion of not only the benefits, but also the risks and alternatives to any procedure or operation between the physician and in the Bahamas, we also say our team because they operate as teams. And so there's no guarantee that there will be a specific physician, but there'll be someone from the team who will be performing or assisting. And that's done with the patient, the next of kin, the guardian, or any legal representative. Now, some of the gaps that we see is what we call non-contemporaneous documentation at the time of the informed consent. And so what do I mean? What I mean is once that is done, we ought to be documenting at the time that that discussion, that dialogue, those questions, those answers are happening so that you have the ability to record it and you don't have to go back and guess. And what is important is that we speak about the patient's desire or consent to proceed should be written in the medical records. And I tell clinicians from time to time when we have case reviews or when I was really working along with legal when I was first called to the bar about the importance of documenting. So, that's your secondary form of, or what I would call your default to ensure that a conversation was had and the questions were answered. So separate than completing the informed consent, what you can document in your progress note is that the patient desired or consented to proceed to whatever it is that you're going to do. Also, very, very important, and I know persons get upset and persons always speak about, juniors have to move forward in order to excel as being senior, and that's important. And so their exposure and their ability to learn new things and even speak to patients, that's important for their growth, but it has to be supervised. Particularly, senior staff must speak in those areas where the risks are higher. What do I mean? If you have critical specialized cases, orthopedic cases, and you have junior staff with you, they do not have the ability to fully explain to the patient the do's and don'ts for them to make a conscious decision. And so you put yourself and the company and the patient at risk because they do not fully understand. And that is why it is so important to ensure that there is supervision when this is done and that the patient thoroughly understands the decision that they are about to consent to. And so I think if you follow that path on a consent form, and for those persons who are living still in the written world where there is no electronic health records, I want you to ensure that at least when you are doing the informed consent process, as this form here, which is a form that is used within our hospital, that there has been an addition of at least 6 spaces that allows the clinician to document the top 6 common risks associated with the type of procedure. This is important because before it only used to be a single line that used to speak about the risks and benefits. This now allows you to put some of the common risks that are associated so as to mitigate some of the exposures. And so really compliance and following the process is really what helps in dealing with some of the litigation. Let's talk about procedural misadventures. And we know that the definition in healthcare of a misadventure is an unintended result of an action. And it arises most in healthcare from surgery. Example, puncture of the bladder, colon, any adjacent organs, anything that went wrong but was not associated with the original procedure or surgery. Some of the gaps that we've been noticing is the lack of reporting of errors or complications that happen. So there is a conversation amongst colleagues, but there seems to be a gap in conversations with the patients. And I'm going to speak about a case that I want to talk about to show you how that case went and caused the PHA several $100,000. Also, we see a gap with a delayed response to meet, like we said, and discuss the event and the way forward. Case management is very, very important. Very, very important. Because sometimes in the cases, you realize that you may, based on trending and looking back at data, you may have to do a peer review. And the peer review is not only for physicians, the clinicians, but any other allied health persons, anybody doing procedures. And sometimes that is important because you now have the ability to stop further errors from occurring, which can result in temporary or permanent damage to patients. And then we see the hesitancy and delay in completing the medical reports. Colleagues, I want to express to you it is important because medical reports are important to be completed when you can actually remember what occurred. We keep talking about the contemporaneous documentation. That has to be there because there are requests that will come in most instances first from the patient, then it will come from the attorney, and will also come from the courts. So the strategy is to verbal notification to your department head of what has happened. Also have that conversation with risk management about the misadventure. It's a misadventure. It's something that was not intended to happen. Complete the institutional form as stated about the adverse event or the incident within the 48 hours. Just complete it. Even if there are gaps, they can be filled, but at least the process would have started. And when the investigation starts, whether it's one that started internally what comes directly from the lawyers, from the face of it, you can see that there was no intention to hide. Speak with the patient and or the next of kin or guardian. Timely completion of the medical report. Had to put it there. Timely completion. I want to talk about this case. We had a case of a 44-year-old female patient. She was diagnosed with uterine fibroids. She was admitted for elective myomectomy and a total abdominal hysterectomy. Following the initial operation, the patient returned to the theater where it was discovered that she had a perforated bowel, which had occurred during the initial surgical procedure. The operative note stated that there was a perforated distal third of the rectum. Secondary to the perforation, um, there was fecal spoilage that went all over the peritoneal cavity, resulting in her having to have peritoneal lavages and a loop sigmoid uh, colostomy. The patient level of care then changed as a result of that because the patient became very septic and moved from med-surg to ICU care. The patient remained in hospital for months during the recovery. Now, this is something that can happen because of the adjacencies of the particular organs. However, this was not the process. This was not the problem. The problem was that nobody knew about it. And what do I mean? There was no initial reporting of the misadventure, no incident form filled. There was just a little notation in the notes. There was lack of full disclosure to the patient or family. The patient did not know fully what had happened to her. It was her perception based on going back to theater multiple times, that everything was secondary to the initial procedure. At one point, the only thing she said the physician stated to her was, "Boy, you almost caused me some problems." And then there was non-completion of reports by the physician, by the nurse who also knew about the process. And so you see, it's a systems issue. It's multifaceted, as well as support staff. The patient remained in hospital for 4 months with no knowledge by the hospital administrator or the principal nursing officer who's responsible for nurses of what was going on with this patient for 4 months. During the period, the patient returned to the operating theater 3 times for peritoneal lavages with a diagnosis of abdominal sepsis. And she had elevation in all of her vital signs and ended up in critical care because of the lack of communication. This information was handed over to us based on a claim of discrimination because the patient was also a cancer patient and they felt discriminated, not only because the perception that because they had cancer they may die, but they also spoke to the fact that they were female and that they were from an area or population where they lived that was considered to be a poor population. That was the perception. We got a writ of summons and a claim to pay for damages up to $500,000. These are some of the things and some of the gaps that must be closed when we're talking about errors. In healthcare, it's not expected that 100% of the time that we will not err in our position, whether we think, whatever we think, whatever methods we choose to do. It is expected. But what is not expected is that we do not have the relevant discussions. So I want to talk about physical assessment. And I intentionally put incomplete because as we review records, we realize that the assessments are not fully completed. And let's talk about it. So we know, and as I start all of the slides, we speak of a definition. So a physical assessment is an evaluation of the body and its functions. using inspection, that's looking, palpation, which is feeling with your hands, percussions, tapping with the fingers, and auscultation, listening again. Well, some of the concerns that we're seeing, though, with the assessment is a lack of documenting physical inspection of the patient's body, particularly the lower extremities. So we see everything, above the breastplate, everything, chest, everything done. But there's never any discussions about their legs, nothing about their back, nothing about their buttocks, nothing that relates to that. We see lack of documentation as it relates to the breakage of the skin. Even if there is a patient that has breakage, there is no documentation of the level of staging. Is it a stage 1, 2, 3, 4, or is it something that's unstageable? The cubitus ulcer patients we see are discharged with dressings done by the nurses sporadically with no written physician orders. But the physicians are aware that the patient does have a breakage in skin, does have a stage 2 ulcer. And so there's no documentation by the patient by the physician during the patient's stay. The only time it's captured is when it's noted by the nurse, or if it was told by what we call the PCAs, the PCTs, or auxiliary nurses, that the patient has a breakage and then it's discovered. One of the things we need to do to correct that is we need to do a complete inspection head to toe on admission. And it's not only a nursing function, but it's a physician function. So it's not only the front of the patient, the anterior, but the posterior. Documentation of the physical examinations of all observations, and even with the wounds, there has to be documentation from the physician managing the patient. The size of the wound, the depth, the color, the drainage, the odor, as well as when we order treatment for it, which is cleaning, you have to talk about the cleaning solution. Does it require a specific type of dressing? Does it require an ointment? The frequency of the dressings, that has to be written. We have paid out multiple dollars as it relates to persons having developed decubitus ulcers in hospital, and separate than it happening while in hospital as a hospital acquired condition, also poor treatment that led to the advancement of the ulcer. Very, very important. Altering of medical records. And some of you may say to me, Dr. Roll, that can't be true. People don't do that. I have seen it. We have seen it. Management of patients must be documented correctly as they occur. Failure to complete can result in inaccurate information, late entry, or jeopardizing your credibility and, more importantly, your license. Some of the gaps we see is we have seen the removal and destruction of the initial documentation. That is not the way to do it. Like I say, everybody knows that we make errors. We call people different names inadvertently. We think we're saying Mary, but we say Jane. Sometimes we think we're writing on the patient in bed 1, Mrs. Jones, but actually we started writing on the patient in bed 6, Mr. Forbes. It's okay, but what you must do is just draw a line through it, write wrong entry, right? Put omitted, date it, print and sign your name, and start off. But you cannot destroy. There has to be a continual documentation in the patient's notes. And we've seen it before because documentation of previous notes were also thrown away. So midway on the paper or at the bottom. And so please just ensure that we are mitigating. It is okay to make a mistake. Late entries must be placed in the notes when you write them. What do I mean? Late entry that is placed after the encounter with no reference is a concern. Make an addendum to the medical records, date it, time it, and refer to the actual encounter. the reason for the addendum, and complete the documentation. Do your signing and your printing. You cannot go and stick it in between, we say. Make an addendum and reference it, and it can always be drawn back. That's important, particularly when you have difficult cases and there may be the perception that you've just added that, which may not necessarily be true. So, the major challenge that we have, the major, we spoke about 9 earlier, the major is the lack of communication. The lack, limited, or not at all, right? So the lack can be omitted, or the pieces that we do tell is not complete. We need to talk about what happened, where it happened, when it happened, why it happened, how we believe it happened and how we can improve it, and whom all may be involved, not for punitive, not for punitive actions, but to ensure that we correct the issue and we avoid recurrence. So communication strategies are so important. And in order to deal with that in healthcare, we need to implement clear standard protocols and clinical pathways for the management of patients, for the handoff of patients, for the referral and consultation for patients. We have to implement those. We have to improve our interdisciplinary collaboration. All parties must be talking. Physicians, nurses, support staff. Everybody must be speaking and working together to improve, to ensure that patients are getting the best care. We have to encourage our patients to understand their conditions and treatment options. And I know this is something that we struggle with patients also accepting their conditions and being compliant. But the more you do that, the more patients begin to appreciate that they understand it. That's why sometimes you got to break it down into ordinary terms. We say in healthcare, break it down to the level of a grade 5 student. We can't just keep using medical terms. It doesn't work. Utilize tools like visual aids that may help to meet the needs of the patient. Sometimes you draw little things. Patients do better with that than anything else. And then encourage dialogue and address patients' concerns. That works extremely well. They may not get the answer that they want, but at least you had the discussion. And most importantly, anytime you have discussions with patients and or families, next of kin, legal guardian, do not hesitate to document those. And so, in summary, with the small time that I was given, I want to encourage you to cultivate an atmosphere of transparency. Very, very important. There's no need to hide. If there are any concerns, let's be transparent. Everything is not punitive. Investigations must happen. I don't know of any clinician making an error that was not a fundamental breach that was fired in the beginning. I don't know. I also don't know of any clinician who went to court and the PHA was found to be liable where they themselves had to pay for the case. Now, these may be things that may change as time moves on based on the cost of litigation, but it's not intended to be punitive in this first instance. Now, if there is trending, we spoke about peer review, and in some instances, it may be wiser for the organization, future patients, and the clinician to not be a part of that process at your facility. Implement quality improvement initiatives and programs. Always aim to do things that are going to improve the process. Not because something is working good today doesn't mean that there's a more efficient way to do things. Always look to improve. Embrace technology. If your phones could do something for you, use that. right? Use your phones to record sometimes if you're busy so that you're able to use it and play it back while you're making your notations, right? At least you will be able to have done that contemporaneously at the time that you are taking care of the patient. Continually supervise, monitor, and evaluate care management. Remember, junior clinicians are placed underneath you. Junior employees are placed underneath us for growth, but they have to be monitored, they have to be supervised, and you have to evaluate. And where you think or where you see that there needs to be adjustment, those adjustments are made. And seek advice if you are unsure. I always tell people, seek advice. There are many people who have done this, been through this, who are also trained, like the lawyers, like the risk managers, like management. Seek first before you make any decision that may come back to haunt you. More importantly, everything that we've spoken about today, I think the most important thing in our approach to minimize and in some instances eliminate litigation in healthcare is really through communication. So communicate, communicate, and communicate. And I say to you, thank you, and I look forward to any questions that you may have. Thank you, and enjoy the rest of your research day.
So you can post it in the chat, or you can open your microphone and let me know what questions you might have.
I have a comment.
Okay.
Dr. Bloomfield.
Dr. Bloomfield, all right, go ahead, sir.
Yeah, excellent talk, Dr. Roll. I just want to make a comment. I think we need to rekindle friendship and respect for each other to avoid some of the factors and the results that you mentioned. There's some people who no longer feel that if they are having a problem with a case, whether active or post-operative, that they can rely on calling for help. This needs to change. People call for help when there is perceived trouble. And it doesn't necessarily mean that you're incapable, but another pair of hands, not a brain, can sometimes remove us from some of these difficulties. There's also a tendency that depending on which institution you're in, then the person who you're calling may or may not respond. And I think it's something that the Medical Association of the Bahamas has to address. When a patient has a problem in the Bahamas, the medical fraternity is being criticized. So we're not removed, not because we were not the physician who was involved. And I think it's something that we have to meet at some point. Dr. Roll, you probably should be forefronting this, getting us to meet and figure out how we're going to move forward. Some of the things that I hear, these are secondhand information, is indeed frightening to me. And I've been a part of this system for more than 40 years. And I need help sometime. I am willing to offer help every time. If somebody needs help and they call me, I certainly will go. And so this is my contribution to this section of the program. Thank you.
Thank you very much, Dr. Bloomfield. Dr. Roll, do you have any comment for Dr. Bloomfield on his points?
Sure. Good morning, everybody. And thank you, Dr. Bloomfield, for your comments. And I totally agree with you. I think, coming up into the system now 39 years, but healthcare, the only thing I know, we have, in some instances, relapsed. And we've also not only lost respect, but I think we've lost the respect of colleagues. I think we have made significant strides between the various levels of discipline, but I think we've lost trust in our ability. And I am always one who is always willing to see how we could make it better for what's happening now and also futuristically. I tell people that is why I am in public health care right now, because at the end of the day, I feel that my only mandate now is to prepare leaders and individuals and to build systems so that when we leave, because we are the aging population, that we feel that we have a safe place to come and to recover. And so I look forward to the ability to work with persons in terms of partnership. And everything that is happening in public is also happening in private. This is a global issue that's going on. But I think because of the closeness, we're a small nation, our ability to come together and to bring change is much easier. And so I look forward to working with individuals. And I think something like this we can definitely strengthen. Thank you.
All right, thank you very much for those comments. But I have a question. So we talk about maintaining trust, inviting persons to speak to us on different things. But is there any procedures that are available for persons to, let's say, speak to a more senior persons if they want guidance? Do we have an open door policy where persons are welcome to come in and ask us questions just in case they might be doubting their approach that they might have, or they might forget something? Do we have something like that in place?
So, Mr. Moderator, I could only speak to that peripherally. I think that would be something for the clinicians, but I know that my office, we have an open door policy. I'm hopeful that the other leaders have one if there are concerns to be able either to come in directly and have that discussion face to face, or whether to jot that and to have that. But I will leave that open to the other leaders on here as it relates to medicine, but I'm sure that that is in place.
Okay, thank you very much. We have another question or comment from Dr. Sinqui, where she said she has not seen the new informed consent forms, and she strongly suggests that we conduct a hospital walkthrough to all the wards to remove the old forms and replace these with new ones. So I think this is a charge for practitioners in the field. Are there any more questions?
Yes, I have one.
Okay, Dr. Moxie.
Yes, good morning, everyone. Dr. Roll, that was a wonderful presentation. I've left the hospital arena. I left the hospital arena many years ago to go into public health and community health and working on the clinic. So, but from time to time, I do refer patients to PMH. My question is, have you ever done an external audit of PMH? And how is it audited now? Is it sort of the Hospital Healthcare Facilities Licensing Board? Or have you ever thought of doing the sort of external audit, JCO audit that Doctors Hospital has, because they have passed, that stringent test. And I believe they're still maintaining those standards. So what is your reaction to what I just said? Thank you.
So thanks, Dr. Moxie. So there are several layers to that. So the hospital has had several accreditations. One is in the lab, and of course, you know that we are CAP certified. So we've had from that perspective. The hospital has been leaning from about 2004 to sort of move in the realm of what was then called JCO, which is Joint Commission International now, that Doctors Hospital has the gold seal for. And when I came from Doctors Hospital at that time, we did a baseline assessment in 2004, and there was another baseline assessment that was just done in 2019 following the JCI accreditation model. So that was able to put us in a position to see what we are doing well in and the areas for which we need to make significant impact in terms of improvement. From an external standpoint, even though we have various regulatory bodies, unfortunately, the public sector is not held to that particular standard. And that's something that needs to be improved upon. But if we were to move in any realm right now with Joint Commission or even the Canadian model, because we ventured in that, we would fail infrastructurally. as it relates to management, care of patient, pathways, all of that, we do extremely well. We would just have to show our records to say that we do this consistently. And if we looked at the patient from beginning, from the admission to discharge, to be able to follow that, I think leadership, clinician, physicians, patients, all of that we won't have any issues with. Our biggest struggle will definitely be infrastructure. I could tell you up front, we would fail that because we are just putting band-aids on every day. But we are moving. I could also tell you that the majority of our policies are aligned with Joint Commission and other regulatory bodies. So we are aiming to do that. But until we can move to get some of the infrastructural works done, right, and all the mechanical, all of those electrical, we won't do so well. So the critical care, in some instances, would more than likely have the ability to pass if we move up to that level. But the other part of the hospital won't. And so that's something that we're going to continue to work on. So as we build new facilities, it's the intent is as we build them, we follow the same model and then move to accreditation at that time.
Good, thank you.
Thank you very much. So just to wrap up, just to go through the comments or questions in the chat and then just wrap up in a minute and then move on to the next presenter. So Aldit's iPod made a comment or a question, how well are we doing in healthcare? And recommend a team approach where the hospital and the team partners with the community healthcare team and the family to help. And Dr. Laville mentioned we could have lectures on such hospital protocols on a regular basis and for all level of staff to benefit from. And then Dr. Conville Brown, you said you have a comment on my question I had earlier. You can open the microphone and go ahead.
Sure, thank you. I hope you can hear me.
Sure.
Sorry, this is in relation to your question with respect to whether or not the hospital or the system has in place any mechanisms to help to mitigate the particular issues discussed by Dr. Albanet. And by the way, Dr. Albanet, Dr. Rule, I very much enjoyed your presentation. That's just this. There is a system, and the system has always been in place. The unfortunate problem is that it is not always adhered to or followed as rigidly as it ought to be. So when we talk about, I think there's just two quick things that we need to consider. One is escalation. So in other words, particularly in the public service where we have a training program for physicians, nurses, et cetera, you literally come from the level of a student all the way up to the consultant, to the head of department, to the head of the hospital, et cetera, et cetera. And so that's a system where you can have escalation so that whenever there is a problem that needs to be debated or discussed, sure, you can do it amongst yourselves and amongst your peers, but then it ought to be escalated. So from the medical student, it goes to the intern, from the intern to the registrar, et cetera, et cetera, et cetera. And even at the level of the consultants, there is the opportunity to escalate, including to risk management and or to hospital administration. And of course, that then brings in the idea of collaboration, where at the consultant level, you need to consult your various colleagues, be they within the discipline or they're outside of the discipline and in another specialty area, but that's relevant to the problem at hand. So either way, there's a system in place. It's up to us to ensure that we utilize it, either escalate up the ladder, you should always escalate anyhow, and the collaboration. And even when we come to the top of that particular program, there are colleagues in the global environment that we can always communicate with, present a problem. I do it all the time in cardiology. And as long as we don't think we know everything, it's easy to reach out and consult with others. And so that would be my quick answer to that. We don't need a system. We need to adhere and implement the system that has always been in place. And that involves those two big things, which really at the end of the day comes back down to what Dr. Rhodes said, which is communicate. Communicate upwards, escalate, communicate with your colleagues, collaborate. Thank you very much.
Thank you, Dr. Brown. So, gentlefolks, we invite you to communicate, maintain a culture of transparency, and also a system of trust in each other. So thank you for that presentation, Dr. Rhodes. So the next speaker is Dr. David Barnett, a consultant orthopedic surgeon, and he'll be looking at legal pitfalls in stem cell research. And he has over 30 years of medical practice, specializing in orthopedics and medical services for the legal profession. focusing on 1, the assessment and management of conditions affecting the musculoskeletal systems, 2, the assessment of cases who have industrial accidents and other litigation matters, preparation of medical reports, and 3, appearing at court as an expert in courts. And he's also an associate lecturer with the School of Clinical Medicine and Research in the Bahamas.
Thank you for having me to present this topic this morning as part of the program Research Day on legal pitfalls in stem cell research and some of the issues surrounding this burgeoning specialty. Now, the presentation will take the form of the legal framework of the research and usage of stem cells, and thus where many of the pitfalls lie. Then we'll look at the further overview of some of the issues mentioned, followed by questions and answers. Go on. So stem cells are really undifferentiated cells that are capable of self-replication, proliferation, and differentiation, so as to become a specific type of adult cell. Now, they've been around forever because that's what repair, replace, and regenerate our cells, as when our cells die from natural wear and tear, the apoptosis. So, however, the research in stem cells really took off in the 1960s with McCullough and Till in Canada. So now we know how research on stem cells, we can look to see how tissues and organs cope with diseases and how these abnormalities can be better, rather manipulated with the use of stem cells. Stem cells also allows us to assess the toxicity, safety, and effectiveness of drugs before we actually apply them, start trials in humans. And accepted aspect of stem cells at the moment are that they allow healthy pregnancies in those with defined reproductive issues, as I will highlight. Now, there are 3 main types of stem cells, and the one that raises most of the legal pitfalls are embryonic stem cells. Now, why these raise such issues as the name implies, that they're actually harvested from the early embryo. So at what is called the blastocyst stage. And at that stage, the cells are undifferentiated. So you can see the benefit of harvesting those cells at that stage is that you can then, you manipulate that cell into whatever tissue you want it to become. But you can see where that raises legal issues. You're actually destroying an embryo. And you can see, yes, the benefits are to improve the life of mankind, but then you have those against who would say, well, some even use the word murder. You're murdering a person. However, as I said, the effects of manipulation of stem cells that are embryonic, the benefits can be seen in now how we look at IVF, in vitro fertilization. I mean, it's one of the standard procedures now that have been accepted from the benefits of the research in stem cells. So it's not going away. The second type of cell is the adult stem cell. This doesn't raise as much legal pitfalls because obviously you have an adult who can give consent. Although when we look at what is called adult stem cell, you have to then look at what happens beyond that embryonic stage, because after they've passed, that cell has passed its blastocyst cell, say the 3 to 5 day stage in an embryo, cells beyond that are called adult. However, as I said, the adult stem cells, the best examples of their usage is bone marrow transplants to treat blood disorders such as leukemia and lymphomas. But we have the issues of biopsying from the central nervous system, which we know will always be a difficulty. The third type of cell in what are known as induced pluripotential stem cells. These are cells that are readily available from blood, skin, or urine, and by manipulating these cells, you can get adult cells to behave like embryonic cells. So, however, as mentioned earlier, if you have adult cells that are 50 years old, you can see, even if you've manipulated them to behave like embryonic stem cells, you still have the problems of premature death. A 50-year-old is going to die on average before a 1-year-old. And therefore, you have other problems such as, well, the cells are more likely to develop tumor, and there's always the issue of them reverting back to the cell that they actually were. Yeah. So, but the positive issues around induced pluripotential stem cells are that, obviously, if you're using your cell, the issues of immune rejection or allergenic reactions are less. And obviously, if they become the stem cell of dominance, then you would need the embryonic stem cells, which, as I said, are the ones that raises most of the problematic issues. So when we look at the embryonic stem cells, they are known as pluripotential cells, meaning that they can be manipulated to form any type of cells in your body. And we can see that when you, obviously, an adult, you can determine, usually, as we heard earlier, you don't go working on someone unless they've given you consent. And it's easy. So when you have consent and rights in there as an adult, you can argue and sign for yourself. However, look at what happens when you're dealing with, let's say, IVF. When things go wrong, as they eventually do, like a divorced couple, you see how then the issues arise of, well, who owns this? Who has? Yeah. So, as I hope to show you, most of the facilities who will offer stem cell treatments will have their consent forms that outlines that. But like everything else, as we've heard this morning, some people don't follow the protocols, and when things go wrong, then that's when everything hits the fan, and you can see how that can raise legal issues and pitfalls. So when we're looking, therefore, at stem cell research and treatment, in the Bahamas, the law that controls what and how we practice in this sphere is known as the Stem Cell Research and Therapy Act of 2013. Yes, the other act that is important for us is the Health, Fertilization and Embryology Act 1990 and 2008 in the UK. And why that is relevant is because, as we all know, the Privy Council in the United Kingdom still is our final court of appeal. So if we have problems and issues that needs to be appealed, they will go up to the UK, and therefore that's the law that they will depend on. So that's what makes it relevant for us. Next slide. So the act in the Bahamas came into effect on September 2013. Next one. And the purpose of the act is obviously to ensure that we have safety and ethical practices in doing this. But one of the things that the earlier slide shows that science outstrips law in its development, but however, law determines what science is legal. So what I'm saying there is that science moves on. Obviously, to change a law, you have to go through all the processes and it doesn't happen overnight. Science can go on and develop overnight. Law doesn't do that. But then it's the law that tells you what you can do legally or if you're practicing illegally. Now, when you're dealing with any branch of life, it's the law that tells us how we behave and how we shouldn't behave. And therefore, the law defines for us what are some of the things we can do and what we can't do. And so because of time, there's some of the definitions that I will highlight, like you can't form chimeras or hybrid animals, meaning you can't bring the genome from one animal to the human to form unique cells, when they are called hybrids, or if you have two types of cells with different genomes circulating in your body, the SCMRs, they're not allowed to be formed. And in fact, if recently, like out of our jurisdiction, obviously, they were able to create half human, half animal. But again, the important bit and the ethics involved is that you shouldn't allow development beyond 14 days, 20 days, because people doesn't want these mythical beings, if I could say to call them that, to be in existence, because you can see what moralistic and legal issues will arise. However, there are episodes and there is evidence that you can see hybrids that occur naturally. And in fact, after bone marrow transplants, some patients can exhibit hybrid behavior. And in fact, for the gynecologists and the obstetricians in the audience, they know about the vanishing twin syndrome, whereby one twin can absorb one another into their body. And in fact, the American singer Taylor Mull is a good example of that, as she's half of her body is one genome and the other half is another. The other point that needs to be highlighted here with the definitions are that what is a fetus and what is an embryo? Because the fetus is thought to be in existence after you've had the embryonic state to birth. And the phase before that is known as the human embryo. And obviously, you can see why these things are defined for you is because, in fact, when you look here, you see human embryo, the first cleavage of the fertilized egg to 9 weeks of gestation. It points to what law tells you what might be an abortion. When the abortion finishes and when you are destroying an embryo. However, we will go on to see that when we are looking at manipulation of embryonic stem cells, because as I said, that's the type that causes a lot of legal problems. The law tells us that, as you see here on this slide, the primitive streak is when that embryo begins to have feeling, when they have a nervous system. So the law tells us that we should not be manipulating these embryos beyond 14 days. That's the law of the Bahamas. The other thing to mention is that pluripotential cells are embryonic cells, as we mentioned, that can form any type of tissue in the body. And these have to be differentiated from the adult stem cells, which can only differentiate into the type of cell of that original cell. So a blood cell, stem cell will only develop into a blood type cell. Yeah. The importance then of the induced pluripotential cell then is that you can see if you can get that adult cell then to go into another type of cell, you can see why the benefit of that. But as I mentioned, you can see the problems of senescence and early death, the tendency to form tumors are problems that still have not been overcome. So stem cell research obviously is to allow us to use them to enable to improve the lives of us, to rid ourselves of genetic diseases, people who can't have children, whether it's because of frequent abortions, spontaneous, who are infertile. You can see how if you can take their gametes and manipulate them, you can obviously get healthy. I mean, healthy is in brackets because they might have other things that you cannot predict, and we'll be able to give you at least give them the benefits of having kids. Now, the process of setting up a stem cell practice or opening a facility to offer this to the public is controlled by a National Stem Cell Committee, and as you will see, most of the persons on that committee represents important areas of the society. The only other facet that must be is that someone on that committee should have international knowledge in stem cell research, and the person at the moment is Dr. Harry from the University of Miami. The minister refers to the Minister of Health, and he obviously is the one who can appoint a chairman of that board committee. And the committee, and through the chairman, has an ability to summons any person to help them in functioning and obviously improving, adjusting the law to allow practices in this branch of medicine to be legal. Obviously, then they also have the right to summons you on the oath if there's a challenge to what you're practicing or how you're practicing. And obviously you can see that you are on the oath, so you cannot lie or avoid not, because then you can be fined. The prohibited procedures within this aspects of medicine are that you, as I said, you cannot create clones of your genome, although it is allowed to occur if you have a genetic deformity. Then you can then use stem cells to manipulate and get rid of abnormal gametes so you can have a normal child. However, they work with the cells. You can use them to effect and develop stem cells, but you can't use them to produce a child. Like to produce someone who has specific characteristics, you can use that to get around having an abnormality, but you can't use it to produce the blonde boy baby. All of these things obviously allows IVF to be, again, like bone marrow transplant, to be the two aspects of stem cell research and therapy that are standard and accepted. Really, in the Bahamas at the moment, we really don't have facilities that are available to the public per se to have these facilities done through costs, and also through. So what we have in the Bahamas are centers that are offering medical tourism. And you can see, therefore, for us to have this facility, you have to have the finances and the facilities to travel overseas. Therefore, if you are offering this service to the public, you have to follow all the rules of the law. And because you can be fined, and the fine can be quite heavily, as the law says, you can be fined as much as $250,000, or you could be in prison, or even both. But the Attorney General is the one who has to determine whether you're going to be charged. So the law then seeks to guide and apply justice, meaning that the law applies to everyone. But it so happens that when we look at stem cell research, all can be involved in the research, but it so happens the benefits usually accrue to those who can pay. As I said, think about our situation. In the main, we have to travel to access this type of service. So therefore, you can see that at the present as it is, most of us don't have in the Bahamas setting, don't have the facilities to benefit from these advancing therapies. Therefore, so let's wrap up. Therefore, what are some of those issues, therefore, that are important, and the legal pitfalls that we will fall into with this branch of research and medicine? We heard about informed consent earlier, veracity of what you're going to do with the stem cells. You should voluntarily participate in donation of cells. You should not be coerced. You should not be coerced into giving your stem cells, or in the case of gametes, the autonomy to determine what is going to happen with those cells. The issues of confidentiality and privacy is important. And in fact, when we look at the law in Britain, we know now that if you've been conceived by artificial means, you have a right at the age of 18 to determine who mainly would be your daddy, who would be your father, because the mom will be bringing you into the world. The other principle of always being beneficence, that you do good, and also non-maleficence, whereby you don't do any harm, although we know that the process of two determined ones, IVF and bone marrow transplants, can be painful. They also have psychological and physiological effects, whereby patients have to have hormonal drugs to be administered before these processes. So it's not a simple, painful process. The final thing that we'll mention is that naturally the law tries to prevent rogue practices that are punishable by fines and imprisonment, as I mentioned earlier. So the aim really is to make sure that your practice is legal, that are being done are repeatable, safe, and are clean, as death can easily occur from these procedures. And I'll stop there and thank you and be available for questions.
And the final speaker is Dr. Brian Charles, the Managing Director of Sandy Crest Medical Center. He gained a BSc degree in Natural Sciences with honors from the University of the West Indies in 1983, and his medical career began in 1984 at UWI Mona campus in Jamaica, where he graduated in 1989 with honors in pathology. He gained his DM in emergency medicine in 1995, and at the Queen Elizabeth Hospital, he was a consultant in the Accident and Emergency Department for over 10 years. Then Director of Medical Services for 1 year. He was an associate lecturer in emergency medicine at the UWI. Dr. Charles was awarded the Silver Crown of Merit in 2008 by the government of Barbados for outstanding services to the profession, and he has been the Caribbean consultant for the MPS since 2002.
Thank you very much, Alonzo, and welcome everyone. Thank you for having MPS with you this afternoon. It's our pleasure really to be here. And this is a wonderful segment of your conference, and it segues very, very well into what we do all the time. I was particularly interested in Dr. Rowe's presentation, and thank you very much for that, because you've made my job very much easier today. Right, so today's talk really is going to be not scientific, but really to assist our practices, assist in how we can do safe practice. And what I work for MPS, Medical Protection Society, who some of you should know, but most of you all probably don't. And this really is what we do. We are protection for doctors, by doctors, headed by a company in the UK, and we are worldwide. It's a mutual non-profit company, and our philosophy really is to support safe practice in medicine by helping to avert mistakes in the first place. We are all over the world, as you can see from this slide. We are experienced. We have experts in all fields, and if there's any assistance that we can give, it is referred to someone who is as expert as possibly can be. So my disclaimers today are I'm an emergency physician and I'm an MPS consultant. And today I want to outline just very briefly why patients sue. I want to promote safe practice in a few simple steps and make recommendations how to manage common medical legal pitfalls, some of which we have heard before. So who sues and why do patients sue? There are many studies on this, but my favorite one was done in 1984. It's quite an old study, but the same results have come out in studies since then. And this study was done at Harvard Medical Practice, where 27,000 negligent events were examined. And of those negligent events, only 3,600 resulted in claims. However, about half of these claims, there was no negligence and no identifiable injury. And 2 out of 6 of them, no negligence with identifiable injury. And 1/6 of those, there was true negligence. So what does that tell you? If you have a high number of claims, many of them are not really related to negligence. There's another follow-up study on this, which was done in New York, where 4% of admissions had adverse incidents. And in a quarter of these incidents, the quarter of them was a result of negligence, meaning that there was a fault on the part of the doctor or the system at the hospital. But only 1/8 of those claims were subject of, only 1/8 of those incidents for negligence were the subject of claims. So this is proven exactly what we said in the previous slide. And 2 out of 3 claims came from patients with no or non-negligent adverse outcome. So what does that tell us? It says really that if you are negligent, it is unlikely that you will be sued or complained against. Also, if you are sued or complained against, it is unlikely that you have been negligent. These facts do not give us the license to practice however we want. It should not give us any comfort in that our practice, even if we are negligent, we may not be sued. But it does tell us that only a few negligent cases or adverse events are actually sued. So why is that? Why is there the mismatch? Now, I would tell you that in my experience, we have doctors who have extremely poor clinical acumen, but they are never sued. On the converse, we have doctors who are very good in what they do, and they have suits and repeated lawsuits. So why the mismatch? Well, basically, in the mismatch, for someone to sue, there is usually a predisposing factor and a precipitating factor. And those precipitating factors are usually when things do not go right, when patients' expectations are not met. If you have an adverse event or unmet expectations or unexpected costs, then those are precipitated events. But those precipitated events are usually driven by predisposing factors of doctors being in a hurry. They may be rude and they may have attitude problems. They may be scruffy. The support staff are not pleasant, and they may have personality issues. So it is frequently said that if you have predisposing factors without precipitating factors, you are likely to be sued. So this is where the mismatch comes, where you see that when you have been sued, sometimes it's unlikely that you've been negligent. And this is because of communication issues, not errors. So I want to spend the next 10, 15 minutes very briefly going through our medical legal risk. And these, we say at MPS, there are 6 C's to safe medical practice. And this is consent, clinical records or documentation, careful prescribing, confidentiality, competence, and communication. So for valid consent, and some of this has been spoken to already just within this sector, for valid consent, you need sufficient information to be given to the patient or client. The patient or client must have the capacity to consent. The consent must be freely given, and you must be able to prove or demonstrate this. The patient must have sufficient information really to make the choice for what you want to do with them, bearing in mind that one of the primary tenets of medical ethics is autonomy. The patient has to have the right to make the decision for anything to be done against them. And we as doctors do not have the right to force anything on them. So what information needs to be given for consent? Well, we need to speak of the nature of the intervention. We need to speak of the purpose of the intervention, give the risk and side effects, the benefits, and of course, the alternatives or what other options that patients may have. When we ask how much information will be given, it's usually judged on the standard of medical negligence, and that is of the standard of what's given to us by a similar body of medical professionals. So if you were to be questioned as to the information that you've given and whether or not it was enough, the answer would be given by a body of medical professionals within our practice. Now, some information is obviously necessary. No doctor will not give it. However, there's some parts of the information given process that may not be needed. And I usually give an example that a person who makes a livelihood as a footballer will not be given the same degree of information as someone who is a pianist if the procedure that you want to give consent on is something to deal with the hands. So the pianist, because the entire livelihood depends on their hands, you will be giving them more information, more complete information than someone who is a footballer or athlete. And I'm hoping that's pretty clear. It's the patient's best interest must be considered, and they must be told enough to make a balanced decision. So our guidance is that you should give the patient the information that they need about their condition, the treatment, and its prognosis, provide it in a way that they can understand, and you must be able to document that they have they have been given this and that they understand, and be satisfied that the patient has understood what you are telling them. The issue really is, and the difficulty is how do you determine that a patient has the capacity to give consent? How do you determine that the patient is competent? It is in case law that every adult has a capacity to decide whether to consent to or refuse medical intervention, unless it is shown that they cannot understand information presented in a clear way. So persons who are intoxicated and persons who are in pain, persons who are medically or mentally incompetent, those persons will not have the capacity to consent. And if that happens, then you have to seek consent elsewhere. The patient is assumed to be competent and has the capacity to consent if he or she can comprehend information presented to them clearly, if they can believe it, if they can retain it for long enough to consider it, and if they can make a decision. Case law also says that where a patient lacks capacity to consent, then that decision must be given by someone else. If you are treating an incompetent patient, you should always treat them along the guidelines of a responsible medical opinion. And always, if you act in the patient's best interest, then consent really, in an emergency setting, really does not play this. Everything that we've just spoken to does not play because it's an emergency. But if you are in a situation where you have time and you don't need to do a procedure or apply medication in an emergency setting, then you can use a court-appointed consent or seek guidance from a next of kin. And I heard Dr. Rose speak about a next of kin earlier. Our guidance, again, is to respect patients' rights for their autonomy and respect their right to decline treatment, even if the treatment is what we think is best for them, and respect their right for a second opinion. If consent or proper consent is not obtained, action may include, a lawsuit in negligence, a criminal lawsuit in terms of battery, or proceedings for assault. So consent is very important. The second medical legal risk, which you should be very cognizant of, is clinical records and documentation. A medical record is information about the health of an identifiable person that is recorded either by a doctor or by a healthcare professional as in their direction. But in defense of claims, the quality of your medical records is a direct reflection of the quality of medical practice. Now remember that when you are being judged either in law or when you are if your practice or your standard of care is being examined, it is not always examined by someone who is within the medical fraternity. And if the quality of your medical records is poor, then obviously they cannot make a distinction, or they cannot decide that your treatment has been appropriate. So medical records are used for primary or secondary needs. And the primary needs are really to provide a clear and accurate picture of what is happening. It is used as an aid memoir because we should not be speaking from memory, because our memory is poor, especially for complex encounters with patients. And it is used for continuity of care when referring our patients to other colleagues. It's also used as audit, research, and most importantly for me as a medical legal consultant, for legal matters. So what may save you when you're doing quality records is that you clearly identify your patient. Your notes are chronological in that they're in order. They're contemporaneous, meaning that they are written at the same time of the encounter, and they are of a clear structure and written with the involvement of the patient, bearing in mind that your notes don't belong to you or your institution, but the notes belong to the patient, and the notes are only a repository for that patient. So you need to write them so that the patient or the patient's third party can understand what you are writing. Your notes should also have an account of your assessment, the care plan, and the care that you have provided, and also the measures taken to respond to the patient's needs. For consent, explanations and warnings given to the patient must be clearly documented, and you must arrange, if you are arranging for follow-up, it must also be clearly documented. Careful prescribing is the third factor in a safe practice, and the press love it when the doctors slip up. And we have found that prescribing, when you have errors in prescribing, that this is one of the things that that they really do focus on in terms of publication against us, the doctors. So if you're prescribing, and I'm not going to spend much time on this because all of us write prescriptions, and this should be just very, very, very clear to us. Prescriptions must be accurate, must be appropriate and unambiguous. You must have identifiers for both the patient and you, the doctor. They must be dated. Medications must be given in a clear way, proprietary, generic, or both. Your preparation must be documented in your prescription. The dose, frequency of the duration must be given. And in your notes, you must, for a prescription, mention the risk and side effects to the patient, and you must mention about the safe use of your medication that you're prescribing. The fourth item of safe practice is confidentiality. Now, what must be confidential? All information that you glean from your patient in your encounter must not be in the public domain. It must only remain between you and that patient. Remembering that the patient is the patient's information. So if the patient wishes to disclose any information of your encounter, they can do so. You must not and must never do so, because if you breach confidentiality, then that is one of the red flags for a lawsuit. And we cannot defend if you breach confidentiality. But there are times when you can disclose a confidential encounter. It must be, if you do so, it must be done in circumstances that may be justified to a reasonable man outside of the encounter. If you are being confidential, you must disclose as least as possible so that you don't cause the patient to be in harm. So if you're breaching confidentiality, or if you have an instance where you have to breach confidentiality, you should seek, again, consent from the patient. If it is ordered by a judge in a court of law, then you can breach confidentiality. And I must say that if you are asked to provide a report by a magistrate or a police person or insurance agent, then that cannot be, you cannot breach that patient's confidentiality without their consent. It may be a statutory requirement to breach confidentiality if it's a notifiable illness, the most recent one being COVID, if there's death certification, and if there's an industrial injury. Otherwise, breaches are only acceptable if it's necessary to protect the interests of the patient or the public, in other words, the welfare of society. And we frequently see this when we have threats being made to other persons, especially if the person is mentally unstable. You can breach confidentiality in those instances. But if you are going to make an exception to confidentiality, it must be sensibly and cautiously applied, and it must be very well documented that you are doing so. Competence is our fifth factor in medical legal safe practice. Always recognize your limitations and ask for help. And I have heard it at least twice here in this section, where it is important, if you are practicing outside of your scope, that you ask for help. Even senior persons, consultants, if you are in deep water, ask for help. So when you're providing care, you're duty bound to practice within the limits of your own professional competence and ask for assistance if needed. The last one, again, I refer to a slide that I said before in terms of the prevention from lawsuits, and this is communication. Frequently, we communicate with persons to respond and not to react. We need to step back a little bit when we're taking our histories, speak clearly, listen clearly, and get the patient's true feeling for what is wrong with them. Do not interrupt before they have given it. Always within communication, there is the verbal and there are non-verbal actions. Your non-verbal actions are actually more important in terms of medical legal issues than your verbal interaction. I see here that my internet is unstable. If I freeze, it will come back. So it is very important to have a good communication strategy, speak very clearly, make sure you're empathetic to your patients, and this will carry you a long way in preventing lawsuits. So those are just a few things, and we can spend a lot of time discussing these 6 aspects of safe practice. But because we are stretched for time, we only have 20 minutes each, I am going to close the presentation here and allow for some discussion or any questions that you may have on any of these 6 C's. Remembering the 6 C's are consent, confidentiality, clear documentation, careful prescribing, competence, and communication. I thank you very much for your time and your attention, and I open the floor to any questions that you may have.
Thank you very much, Dr. Charles. And I must emphasize, I thank the presenters for this segment, as I realize that much of the talks were surrounded around integrity, trust, honesty, and also having transparency. I'm asking the presenters to place in the chat their email addresses so that persons can reach out to them for further comments or conversation as it relates to their talks. We are running into the next session as we speak, so we are kind of pressed for time. And if any, we can have a few questions in the chat that can be addressed in a moment or momentarily. If not, we will move on and prepare for the next section.